Hi, you are in the ladies' room with Dr. Donica, the only public ladies' room you can enter anytime without ever waiting online. I'm your host, Dr. Donica Moore. We'll be having real conversations with real women about really intimate issues. They may be embarrassing, sad, or funny, but they will always be interesting and informative. You know, like the best conversations you've had in ladies' rooms with your best friends, or total strangers and a physician. Please join us. And welcome, everyone, to the ladies' room. It is such a pleasure to have my guest today, Dr. Octavia Cannon, because we are talking about taboo topics in OBGYN, something every woman can relate to. But what is taboo? The dictionary definition is anything prescribed by society is improper or unacceptable. But for our purposes, it's also anything that society prescribes is inappropriate to talk about in public. So yes, of course, we are going to talk about all of those things. We're going to touch on everything from how you really get bacterial vaginosis to injuries during sex. And yes, men, you can get a penile fracture, to the proper hygiene necessary if you switch from anal to vaginal sex. And knowing me and Dr. Cannon, we'll probably cover many other tangential topics as well. Now, Dr. Octavia Cannon is the co-owner of Arboretum, Obstetrics and Gynecology in Charlotte, North Carolina, and president-elect of the American College of Osteopathic Obstetricians and Gynecologists, which she fondly calls ACOOG, since that is a mouthful. She becomes president of the organization in April, so let us be the first to congratulate you.
Thank you.
And prior to joining her current practice in 2005, Dr. Cannon served as the Director of Women's Health at Gaston County Health Department for 6 years. She continues her personal mission of public service and health education through numerous local and national leadership roles, in addition to her involvement with ACOOG and with doing things like talking to us today. Dr. Cannon is an honors graduate and an active alumna of Johnson C. Smith University in Charlotte, North Carolina, where she was a Duke Endowment and UNCF scholar. She earned her medical degree at Nova Southeastern University College of Osteopathic Medicine in Miami, Florida. She then returned to her home state of Michigan for her residency training at St. John, Detroit, Riverview hospitals. But the highlight of her career is talking to us today. Welcome to the ladies' room.
Hello, ladies.
So, have you ever done an interview in the ladies' room before?
Not on purpose, but it has occurred.
Yeah, I'm sure anytime you're in the ladies' room and women find out you're a gynecologist, they just want to ask you all of their questions. So I have to ask you my first question. What was the most unique, memorable, unusual, or interesting conversation or encounter you ever had in the ladies' room?
Well, one I can think of right off the top of my head is when I was in the restroom. It was some kind of event, and there were two ladies. I think they were just coming out, and I hear one go, ugh. The friend says, "What's wrong with you?" She says, "I cannot get rid of this odor." And her friend said, "What kind of odor?" And she said, "It smells like cat pee." And her friend started laughing, and then I start laughing. And then by this time I'm coming out, and I said, "I'm sorry, I didn't mean to eavesdrop." I said, "But I am a gynecologist." So the three of us start laughing again. And I said, "What does cat pee smell like?" I said, "I don't have any pets." She said, "Well, I don't eat it, but it's what I imagine cat pee would smell like." She said, "It just smells like, you know, if you're driving behind a garbage truck in traffic and that juice comes out, that bad smell, garbage truck juice." Now that I had heard of people saying before, garbage truck juice, which is even more gag worthy. But she said, "I can't really describe it. It's just not my natural smell. It smells kind of fishy, kind of just really horrible." And then her friend is looking at her laughing, but in a way that she's like, "Yeah, I kind of did that smell too." So we just start talking about it.
We call that an offensive odor.
Yes, or malodorous discharge. Right. Right.
And just so, not to interrupt, but just so everybody who's listening knows, every woman has a natural odor.
That is correct.
The story is that it's not her natural odor.
Right. And I think that sometimes women expect not to have a bad odor because they use body wash or they're very clean, things like that. But it's not really about being clean. Sometimes it's about what you ate or didn't eat. It's about not drinking enough water. It could be about just your partner, you know, passing infection back and forth, bacteria back and forth.
Or what you did last night.
Or what you did last night, right? Yeah, because sometimes it's just your natural pheromones, your natural hormonal scent. And, you know, this is what cave women used to attract cavemen way back when.
And it
So
depends on where you are in your cycle too.
absolutely, absolutely.
But what did you tell this woman?
So we just, of course, after we kind of look both ways and make sure there aren't more people in there listening to us, I kind of quickly say, well, what kinds of things do you do? My first question is always, do you sleep with panties on at night? And sometimes they say yes, sometimes they say no, sometimes they say, well, I'm trying not to, things like that. Or if I did, my husband would be all over me. I have to wear panties to bed, which I always find hilarious.
Right. What kind of husband is deterred by panties?
I don't know. I think the less work they have to do, the better. I'm not sure. But, that's one of the main causes of yeast and bacterial infections, because they love that warm, moist environment. It's kind of like you're giving them a petri dish to grow. Remember that petri dish back from high school when you had to grow stuff in bacteria in biology class?
You put the lid on top.
You put the lid on top. The lid would be your panties. So you really, just like your grandma used to say, you have to sleep without your panties and let things, quote unquote, air out down there. And your body is the largest, or the skin is the largest organ of your body, and it needs oxygen. So unless you're on your cycle, you should stop wearing panties to bed around 12 years old.
Yeah. I actually did an interview on this for a online reporter, and everything she wrote in the article was fine. But, they always have somebody else write the headline. And so the person who wrote the headline wrote, I said basically exactly what you said, but the headline said, gynecologist recommends that women never wear panties.
Oh, geez. Yeah. I mean, I actually did not know that someone else writes the headline. That's interesting and explains a lot. But what I always say, my mantra is, last night was the last night for the drawers. Okay, stop wearing those panties. And usually it gets a quick laugh, but it really is true. Last night was the last night. No more of that unless you're on your cycle.
Well, I think it's interesting how you approached these two women and you asked her about the panties issue, because she was probably trying to guess whether the right answer was supposed to be yes or no.
Every time. It's so funny you say that, because you can tell sometimes when they answer, they'll say, well, sometimes I do. And, their eyes are shifting back and forth because they don't know what the right answer is. And I'm fine with that. I'm not trying to, pull shade and make them be wrong or give them a gold star for being right. I'm just trying to get to the gist of their problem.
Yeah, I learned that when I was 11 years old. I was in the hospital after a car accident, and there was this very stern nurse who used to come in every morning and ask me in this very demanding voice if I had moved my bowels. And I had never heard that expression before. And I thought I would be in trouble if I moved the bowels. I had no idea what that meant. And so I was like, no, I didn't. And so they wound up keeping me in the hospital and giving me all kinds of extra medication, just because, of course, I couldn't be discharged if I didn't go. And I think I kind of figured out what they were talking about.
Yes.
It's so important in medicine.
Yes.
So you're talking to a child or an adult who's just not familiar with a term or wants to please you. So anyway, I'm assuming you assumed that she might have had bacterial vaginosis. So
yes.
That's with her the other possible causes of bacterial vaginosis?
Absolutely. Many of them. Another big one that I find, especially with teenagers or young college-age women, is they're wearing thong underwear every day. And you think about it, when you put those thong underwear on, when you sit down, that string slides from the back part of your bottom, the anal area, right into the front. And that's that bacteria, the Gardnerella, the kind of bacteria that causes the bacterial vaginosis. And you keep wondering, why do I keep going to the doctor and getting treated, but then I keep getting it again? Well, it's because you're wearing those thongs.
Not wiping properly,
or not wiping front to back, because when you get up in the middle of the night to pee, all you want to do is just stop dripping, and you're just going to get on back into bed. That happens a lot too. So that's another huge one. Another one is if boys don't aim so well sometimes. I shouldn't say boys. Men don't aim as well sometimes, and they think it's a big deal and that they can master their penis without holding on to it, and instead of touching right into the vagina, they touch your anal area, and then they go in.
Do that by accident. They never
absolutely
of course.
No, absolutely never on purpose, but it does happen. And that who's going to stop it after he's put his penis in and say, oh wait, I need to wash? No one's doing that. So sometimes you just got to get up afterwards and go to the bathroom, just go pee. And if you can, just wipe down there front to back to kind of clean the area.
Another wants to talk about the other issue is the, switching from anal sex to vaginal sex.
And that's just where I was going. We think alike. So, that's the biggest one. And that's another one where they're not sure which answer to give. If you are having anal sex and he doesn't wash off his penis or change the condom before he inserts his penis into your vagina, then you're absolutely going to expose yourself to bacterial vaginosis and that cat pee smell. So that's a really important aspect. And it's funny, some patients will be like, oh, no, I never do that. And other patients will go, oh, like, okay. So that's definitely a big one. And I even had a patient bring her partner in the office because I kept telling her, that's why you're getting it. And she would say, okay. And I think finally she just got tired of trying to explain that to her partner. And he probably said, you just don't want to do it. I just, this kind of thing. And, as long as it's something that you're consenting to and you want to do it, and some people find it enjoyable, you just have to be more hygienic with it. So she brought him in. He never looked up from his cell phone, barely to even shake my hand to look up from the cell phone. And then I say, so is your partner circumcised? And he doesn't say anything. I go, sir, are you circumcised? Because you're in my office now. We're all going to participate. Group participation here. So he goes, yeah, I'm circumcised. Because that's another way. If your partner's not circumcised, that yeast and bacteria can harbor behind his foreskin, and you could get it that way. So then we were talking. I gave the whole spiel about, that you could get it if you don't change the condom or wash your penis off before you go from the anal area to the vaginal area. And then the patient looks at, if the definition of side eye is when you just, sometimes you turn your head and sometimes you don't, and you're just kind of like, oh.
Some women are really good at it.
Really good at it, because I tell you, if she had daggers in her eyes, he would have been sliced up like a ham.
Yeah, I'm not good at the side eye, but I'm really good at the one eyebrow.
Oh yeah, both of those in the same category. It's awesome.
Yeah,
but anyway,
that's a bad luck.
Yeah. That is very true. The patient then gives him the side eye, but he's looking at his phone. But it was then clear to me that's what was happening. And she clears her throat, and he looks up like, what? And so she said, she just said what our problem is. And then I think he was embarrassed at that point. He just kind of put his phone down and was listening at that point. But I didn't see her back until her next annual exam. That solved the problem.
That works. So yes. How often do you have women patients who bring their partners in to see you?
It depends. Who are not pregnant, right? So if they're pregnant, it's a whole different story. But many times I have patients bring their partners in, number one, because sometimes the partner is interested. What goes on there? Why are you there so long? And why are you happy when you come back? Well, really, it's because they like their doctor. But other times, if there's an issue that involves both of them, and many times it does, they want the partner to understand from a doctor's perspective what's going on. If it's a married couple and somebody comes up with a sexually transmitted infection, that's a big one. Sometimes it depends. It depends on whether the partner has admitted, or sometimes it's the patient. Don't get me wrong. Sometimes it's a patient who's, kind of stepped out and, gotten an infection and passed it along to the partner. But, I really am just...
Actually, let me just interrupt you for a second. One thing we really have to say about bacterial vaginosis is that does not come from somebody stepping out of the relationship.
That is correct.
That's, something that I really have to convince people of, because they're it's so painful. Also, we talked a lot about the odor.
Yes.
It feels like your lady parts are on fire.
Fire. Yes.
And, your vagina is not something, or actually we should be correct. Your vulva and your vagina are not things you should be thinking about during the day.
No.
You're thinking about what you're going to do with them. And this is something that you just can't get away from, that discomfort. So I think we should also talk about how it's treated.
Yes. So that, that itching and irritation can be horrible. And additionally, it can aggravate your bladder, which then causes you to pee more frequently, or just feel uncomfortable, even have some bladder pain, and you're not sure if you have a bladder infection or if something else is going on. Which, by the way, a bladder infection and UTI are generally the same thing. I have a lot of people that say, well, I thought I had a bladder infection. What's a UTI? It's pretty much the same type of thing.
And UTI stands for
urinary tract infection.
So technically, it could be anywhere in the urinary tract. So it could be in the urethra and or the bladder.
Absolutely.
And just so everybody knows, when your doctor says cystitis, that is also the same thing. Yeah.
Right. That means inflammation of the bladder. So
we're all big about, in the ladies' room here, defining our terms. My biggest pet peeve is when people refer to the vagina to refer to everything.
Everything.
And I did have a thing with another reporter where we were talking about, she had asked me about shaving your pubic hair during pregnancy and whether it's safer to shave or wax and, what some of the issues were. And of course, my main point was you really don't have to do that at all. Ever.
Right.
But we went through all the issues. Again, she did a great job with the article. Everything was accurate. But the headline was, "Don't shave your vagina during pregnancy."
Oh, geez.
And I went outraged, and I called them and I implored them to change the headline, because of course the punchline is you could never shave your vagina. Shaving the pubic hair in your vulva area, in your mons, hopefully not anywhere else.
Right.
But your vagina does not have any hair.
Yeah.
I'm always telling people that's the inside part, not the outside part. Anyway, so back to the treatment of bacterial vaginosis.
So there are several options for that, thankfully. One, and patients interestingly always ask me which one is faster. Dude, they all work, just whatever you want to do. But pills, there are pills that you can take. And sometimes the pills do have a bitter aftertaste. And there are a couple of types of pills that will do not recommend having alcohol with them at the same time. So if you come in on Friday to get ready for the weekend festivities and you have bacterial vaginosis, you might want to wait until Monday before you start the treatment. I think it depends on which one is more important to you. Do we want to smell like cat pee, or do we want to?
If you have the pain, you should get.
You can't wait. You can't wait.
And what I tell everybody is, you don't have to give any excuses or reasons that you're not drinking. And if you feel like you need a reason, you can just say, I'm on antibiotics. Yeah. However, what's the big risk of being on these antibiotics?
Nausea and vomiting.
And you could get a yeast infection.
Right.
So people will tell me, I did the treatment. I took all the medicine and all my symptoms are back, except this time I have a white discharge.
Yes. Yeah, and so that's always problematic. But many times, if you know your patients, or if your patients know their body and say to you, it doesn't matter what kind of antibiotic I take, I always get a yeast infection afterwards. That's an easy fix. We give you a pill for that.
Yeah, and what I recommend also to everybody, whether they're taking antibiotics for this or pneumonia or anything in between, is that I strongly believe that you should take probiotics anytime you're taking antibiotics.
Yes. And the thing to remember about that too is make sure it's a probiotic for vaginal health and not a probiotic for gastrointestinal health. Because you'll be pooping really well and then you'll get more BV because you're putting poop in your vagina when you're wiping so much from pooping really well.
So without, obviously you're not endorsing any one particular probiotic.
No.
But what probiotics do you recommend for your patients, particularly for vaginal health?
So there's, acidophilus really kind of is the most preventative for yeast. And then there are some, and there's one I know that, I'm not really endorsing. I just know that my patients use it a lot, and it's Refresh Pro B. That's the brand name of it. But then there's another one that's called Femdophilus too, which I think may not be the brand name, but it has the particular probiotic ingredients to fight the BV, and BV meaning bacterial vaginosis.
And lactobacilli is what we're looking for. So what I always tell people is, if you have a probiotic, you're looking for things that have the highest number of colonies.
Yes.
So the largest number on the label, and you're also looking for something that has lactobacilli in it. And if it has lactobacilli, we're good. So I think that's very, very helpful.
Yeah, it's important to make that distinction again, because I had a patient who kept getting the bacterial vaginosis and I was telling her how to get rid of it. And she came in, she was so angry with me and upset with me because she was like, you told me to get this and now it's giving me diarrhea. And I said, well, did you bring the bottle? Yes. And it was for gastrointestinal issues.
Okay.
So then of course they feel like, oh, sorry.
Well, that's actually a great suggestion. One of the tips that I give patients anytime they're taking over-the-counter medicines or herbal supplements or even vitamins or other prescription medicines from other doctors, bring your medicine.
Bring them in.
Because then your doctor can look at what the dose is, what the ingredients are. We're not all familiar with every single over-the-counter medicine that there is. Many of these OTC products, especially now that we're in cough, cold, flu season, have
Yes.
multiple ingredients. So you could actually be double dipping if you're taking, cold medicine and your allergy pills, for example.
Excellent point.
So I
Excellent
think
point.
that's really important. So what do you think is the most taboo topic that your patients are uncomfortable talking about or reluctant to bring up?
So I think there are a couple, but one that comes to mind is whether or not it's okay to have sex while you're pregnant. Yes, many times it's funny. If the patient's partner comes and they ask about sex, you can tell which of them really want the sex based on how the question is asked and whether or not, again, the partner is paying attention or looking at their phone. But the short answer is,
we need to get you a sign that says this is a no phone zone.
Right. And we actually do have those, but it really only applies to when you're trying to get the patient's vital signs so they're not talking during the blood pressure. But yes, I think that it's fine unless your doctor has specifically said you cannot do it. You're preterm labor, you're having contractions, your placenta is too low and you might bleed, things like that. It's absolutely fine to have sexual intercourse during the pregnancy. And if you're worried about it, just ask. But many times I think men, so I think their egos are bigger than their appendages.
And another piece of real estate. I refer to it as a small piece of real estate.
Yes, small sometimes, but they think that they're going to hurt the baby. Right. They think that when they're actually touching the cervix, they might be touching the actual baby's head, something like this. I've heard that a lot. And I had another patient who said that, I think her husband was kind of grossed out by her belly being so big. And I'm not kidding. They were literally, and he was there and he felt so embarrassed and apologetic about it. He said, I don't know what it is. It just, your belly was on me and I just couldn't do it. And he was just, and he was like, mortified. Like he said, I love her so much and I think you're beautiful, but I just felt like it was the baby between us and Well,
and that's when it's time to experiment with different positions.
And that was exactly what I said.
Pillows are your friend in
pregnancy. Right. Because I think in their case, that's what fixed it, was trying different positions. So, but unless your physician says to you or your caregiver says to you, you really should not have intercourse while you're pregnant, then it's usually fine.
Right. And at the end, it can help trigger labor.
Yes. And if they ask me one more time, how can I make this go faster? Yeah. I am not your uterus, cervix, vagina, baby. I don't know. But this is something that could help. And then one is like walking, walk in the mall if it's cold out, walk outside if it's beautiful out. Or intercourse. The sperm has a natural prostaglandin, prostaglandin is the hormone that helps to make your cervix ripe and be accepting of the labor-inducing hormones. And, that may help you.
And my personal favorite, nipple stimulation.
Absolutely. Same principle with that.
Yeah. On Grey's Anatomy, they actually had a doctor who liked to practice that herself on the patients. Did you see that? Oh,
yes. I admit that is one of my guilty pleasures. I've been watching Grey's Anatomy since it came on, and it's so ridiculous, but it's so great at the same time.
So ridiculous. I love to solve every single problem from the time the patient comes in to the diagnosis, treatment, surgery, recovery, complication, romance, and discharge, all within 45 minutes. Right.
And I've never seen or heard of physicians having so much sex in a hospital.
Oh, well, I could tell you some stories.
I'm not saying I don't know a few, but it seems like they have it on the regular. Never seen that.
Right, on the regular.
I guess I was too busy working.
Yeah, that's true. Yeah, I have some stories.
Right. We'll talk later.
Topic.
Yes.
We'll call it. So other taboo topics that patients are uncomfortable talking about or that you're uncomfortable talking about with them.
So now there are a couple more there too. And it really starts with even my nurses being a little uncomfortable, but I always depend on and appreciate my nurses because they're the first person, well, really the second person that the patient sees upon presenting into the office. The first one is the secretaries or the receptionists that sign them in. The second is the nurse. And sometimes they can tell something's wrong or they're saying, I get a weird vibe from the partner. And it's not always male partners. Let's be clear about that. Yeah. But domestic violence is a big one for me. And I think the second one is substance abuse. But sometimes I think that after doing this for so long, you can kind of get a vibe on whether there's something going on. Hopefully that you can. But if they're a new patient to you, sometimes it takes a little more work. But certainly those are two subjects that are hard to broach, particularly if the partner will not leave the patient's side.
Yeah.
So that's
do
difficult.
You ask the partner to leave?
Many times we do get an opportunity in there, but if I'm really concerned, or sometimes the patient will give you, I don't know how to explain it other than maybe like an expression, or they'll do something with their eyes, or they'll do something that gives you a hint. And I'll be honest, I've had that happen only a couple of times where I really was almost afraid for the patient that I would ask the partner or whoever's with them to leave, because many times, as I said, it could be a male or female partner, or it could be, if they're less than 18, it could be a parent.
Mm-hmm.
So
yeah, I actually learned this technique from my children's pediatrician when they hit a certain age. I think it was 14, maybe. She said to me, just very matter-of-factly, at this point in the exam, we always ask the parents to step outside, and, we want them to learn to be with the doctor alone, and then we will call you back in at the end.
Yes.
And, my kids did say that's when they got asked the, domestic violence questions. And I thought that was very
smooth. Good.
She was smooth, and she just made it matter of fact. Like, at this point, we always do this. And I thought that was a really good way to handle it, because we just did a great interview with a woman who was, brave enough to come on our show and talk about her experience as a victim of domestic violence with her ex-husband through 2 pregnancies.
Oh my!
And it was, it was a very, very emotionally powerful interview. But it was a topic that I really wanted to talk about from the perspective of being an adult woman in an abusive relationship. But then I also added my perspective of having grown up as a child in a domestic violence situation.
Yes.
And there's 15 million children a year who are exposed to domestic violence. And we've all heard the statistics about the percentage of women. 1 in 3 women has at some point been in a abusive situation, either physically or terribly emotionally and psychologically abusive. And this woman talked about how the emotional and psychological abuse was actually worse than the physical abuse.
And that is so true. I agree. Because the physical abuse
described was terrible.
Yes. But the emotional abuse leaves no scars. It's external scars.
Right.
Visible scars.
Certainly women who were in abusive relationships. 15% of all gun deaths in this country are from domestic violence situation. That we're calling it now intimate partner abuse.
Yes.
And I give a lot of credit to Oregon, who just passed a legislation to close the boyfriend loophole, which is in many states, you could only be prohibited from having a gun in domestic violence situations if you were married.
Wow.
And if you were not married, that law didn't apply to you. So Oregon just closed that loop. Other states are looking at it. So hopefully other states will follow suit. But
I agree.
I think if, in the gynecologist's office, I want to encourage any women who are listening, that is a great place to open up, because of course we have complete confidentiality. But most gynecologists know exactly who to refer you to and how to get you the help that you need.
And it's easy and it's discreet to do. And one clue is when you're asked to give a urine sample, the partner, whoever's with you, usually goes in the room that you're going to be examined in, and you can take that moment when you go to the bathroom or when you're coming out to try to say something quickly if you're afraid. And that's many times that's when we get the hint that something's going on. We can get that help. Thankfully, I've never had an issue in the office where the police have to be called, but it's definitely happened in the hospital.
I had that one time. I had that situation. So do you routinely ask all of your patients domestic questions to screen for domestic violence, or do you just ask some of your patients if you feel like you have a clue or a suspicion?
I think it's a little of both. I think, and I will be honest and say I'm guilty of not asking everyone every time, because again, it's that discomfort factor. But I also know my responsibility as a physician and a caregiver and someone that might be the only person they can trust. So I think that over the years, I've been able to do that more, but I did not always do that. to every single person. I think that our nurses do a good job of asking those questions too, but they feel uncomfortable too, and they've told us that. But it's all about teamwork. So, you know, that's certainly our goal. And then many times you are able to see signs, as I mentioned, but sometimes everything seems just as perfect as it could be. And those, to me, are red flags.
Right.
If he's so, you know, he's extremely doting, he's asking questions, and, you know, I've had gentlemen come to the ultrasound to find out the sex of the baby and wants to know, well, why do you have to touch her there? Why are you doing that there? Just think, really odd questions. And then our ultrasonographer would come in and say, hey, you know, I think, you know, because they'll see, the ultrasonographer would see them before I would, and, you know, she would say, hey, something seems weird about this. I just want to tell you.
And this is one of those, if you see something, say something.
Say something, exactly.
Or if you suspect something, say something.
Yes.
Now, many times domestic violence occurs within the context of drug and alcohol abuse. So let's talk about how difficult that is to talk about. That
is also difficult, but many times you are able to just, even before you start, by saying, now, normally we would do, especially if they're pregnant, normally we would do a urine drug screen. Are you okay with that? And then you might get some pushback there, or sometimes, even this happened to me last Friday, the patient said, so I'm just going to be honest, I've been really stressed out about this pregnancy, and I did smoke a little weed. That's exactly what she said. I said, okay. I said, you know, there are no judgments here. Our goal is to help you and, you know, have a healthy pregnancy and a healthy baby. So that usually puts patients at ease. I don't get too many patients who are angry about the question, but some, you can often tell if there's something going on. And then we just go on and ask different things. Of course, if you smell something, that's the first red flag. Or you may not smell it on the patient, but you smell it on the partner. That's another one. Or if they just seem like they're out of it when they come to the office, something doesn't seem right. If they're asking for more pain medicine, first visit, they're asking you for pain medicine for a chronic pain condition they've had, and you have no records, things like that. So that is also one that's difficult, I would say, though.
Did your headphones fall out?
One of them. The other one I can hear you well.
I need you to put it back in.
Got it.
I had a situation once, you know, this issue of the woman who confessed that she smoked a little weed. She was probably feeling really guilty about it and needed that sort of confessional kind of thing. And it reminds me of a patient I had once when I was in residency. She was from another country. Her English wasn't great. And she had a botched abortion, and she was septic. And, you know, we did everything we could. You know, we saved all of her organs, you know, everything was good. And on discharge, I said to her, you know, I went through all the instructions and I said, do you have any other questions? And she said, well, I just want to know when I can get pregnant again. And I had to really hold back because I was like confused. And I said, well, you just had an abortion. Why are you in such a hurry to get pregnant again? And she said, I had an abortion because I had x-rays before I knew I was pregnant. And I knew x-rays were bad when you're pregnant. And she didn't say to the doctor that's why she wanted an abortion. She just thought that he had done something terribly, terribly damaging to the baby. And, you know, thought that that's what she had to do. So that has stayed with me for 25 years.
That's horrible.
You know, just really it's kind of a good reminder to see the guilt that we place on ourselves for things like smoking a little weed. Or I can't tell you how many pregnant women I've talked to who were distraught about the fact that they had been drinking before they knew they were pregnant. You know, and no, that's not ideal, but it is not something anybody needs to feel guilty about. And it's not the end of the world. And of course, we're going to monitor everything to make sure everything is fine. So it would not be right of us to be two women, two doctors talking about taboo topics in the ladies' room where we open up about everything and not talk about the things that we're a little uncomfortable talking to our own doctors about. So you want to go first or you want me to go first? Since we're confessing.
You go first.
For me, the most uncomfortable topic is talking about my weight. You know, I know that I am 20 something pounds overweight. I know I need to do something about it. And I don't want the lecture. And of course, my doctor never gives me a lecture. But there was even one time where I went in and I said to the nurse, I just cannot be weighed today. I just can't.
I just can't do it.
I'm not able for it. And as a physician patient, I thought this was like a horrific request to make. And I was surprised when she said, okay, fine, we'll just skip that today.
Yeah.
And it was just like this tremendous relief. But I actually, even when I was pregnant, that was really stressful for me. And my own OB told me that he had patients who he suspected canceled some of their prenatal visits because they just didn't want to be weighed. So for me, that's my taboo issue. And I know that when I talk to patients about their weight issues, I feel like super hypocrite. I feel like, the doctor who smokes, who tells their patients they shouldn't smoke.
Right.
And I have known doctors like that. So your turn.
Okay, so I should have gone first because that's mine too. Yeah, that's a big one for me because other stuff I'm completely open with. My gynecologist, who's actually my primary care too, I know her as a friend. So I would always be like, you see anything down there? You see anything going on there? Doesn't need to be going on in there. Things like that, I'm pretty open, but the weight thing is huge for me. I too am in that category of I know better, but and when you know better, you're supposed to do better. But yeah, not really happening for me. So I've never said I don't want to be weighed, but I'm already giving the disclaimer of like, yeah, I know I'm overweight.
Yeah, I did.
So don't say anything about it. Yeah, I mean,
take off everything. I take off my shoes, my watch, and the whole thing.
Right.
My gynecologist is also a personal friend of mine. And she's a couple of years older than me, but she's like Iron Woman. She, is in perfect shape. She bikes, she runs, she cross-country skis. She's like super, super fit.
Yeah.
And I always feel like she's thinking, okay, why isn't everybody like this?
Right. Yeah. Yeah. But again, that goes back to that self-guilt, Doc. Yeah. Because I'm guilty of it too. And I agree with you when you're talking with patients in the office, the same thing. Some patients say, well, why can't I get pregnant? Or why am I bleeding irregularly? It could be your weight. But I always put myself in there with them because what I'll usually say is, now I'm the last person that can talk about somebody needing to lose weight or being overweight. I said, but many times the fatty tissue or the tissue we have around our middle, and I always say we because I've got it too, is that it harbors estrogen. So that extra estrogen that you're getting along with or without your birth control pill, if you're taking hormones, could make you bleed irregularly. So too, it could make you have problems with fertility. And then I say to them, I know you see a 500-pound lady walking around pregnant and you're like, how did she get pregnant if it's weight issues? It's not always that, but every person is different.
Every person is different and every situation is different.
That's right.
And it's, when you look at all of the different health issues that weight affects, and there are many health issues that being underweight can also affect, including just even getting your period. But if we're talking about being overweight, there are even skin conditions that are affected by being overweight.
Absolutely.
So, and certainly odors and, heart disease, of course, is the number one, but even breast cancer. Women don't always associate that with all of their risks. So that's a big one. Speaking of taboo topics, there was a great survey that was done, a survey study a few years ago that looked at the top things women lie to their doctors about.
Oh, do tell.
Well, of course, I thought weight was going to be number one. But you know what was you'll never guess what number one was. And I was shocked. And I thought this was kind of a trick question because I don't even think doctors even ask this.
No.
And that was the number one thing is about brushing and flossing on a daily basis.
You're kidding.
That's the number one thing. And I
thought, that's so huge.
It's huge. And it's connected to your risk of heart disease, your risk of stroke, not to mention your oral health and risk of infection in your immune system. But
especially when you're pregnant.
And exactly. And I did not think about that being a general medical question that most doctors would even bring up so that patients would lie about it. Of course, I lied to my dentist about that.
But you know, they can tell when you're lying about it.
They know you're lying.
Right.
They take one look at your gums.
And you're
and they know that that morning was the first time you really flossed very, very thoroughly.
Yes, yes, yes. I personally am obsessed with flossing. I have it in my car. I have it in my purse. I have it at the office. I'm obsessed with that because I never had braces and I never want to have any things with your problems with your teeth. And my dad was always big on that. He'd say, well, you don't have to brush all your teeth, just the ones you want to keep.
That's
right. So, you know,
I'm in that. I never had braces at all, but I'm in that situation that a lot of postmenopausal women find themselves in and don't necessarily know that this is associated with menopause, is that after menopause, your teeth definitely shift.
Yes.
And you get bone loss in your jaw.
Yes.
So I'm announcing this first to you since we're talking about confessional things.
Okay.
I'm actually about to get braces for the first time.
Wow. Okay.
So just so I can correct, I have actually like 2 teeth that are just really bothering me because they shifted so much and it never gets better. You know?
Yeah.
So, and there are a very high percentage of women who actually lose all of their natural teeth due to osteoporosis and of the jaw.
Nightmare.
So that was number one. Other things that in this survey that patients lied about. The next one was the number of sexual partners. And I think some doctors may harp on that a little bit too much. I don't need to know how many sexual partners
I don't either.
you have.
Yeah.
I just need to know, is it just one? Is it a mutually monogamous relationship? Or if it's more than one? And quite honestly, I think nowadays, certainly most gynecologists are treating most patients as though they have to be screened for everything, because who's the last one to know she's no longer in a mutually monogamous relationship? Right. Very true. So it doesn't really matter if it's you or if him or both who are stepping out. It just matters that we need to know that there's a risk, which actually brings me back to something we forgot to talk about earlier. When we were talking about bacterial vaginosis, and I was saying about how I find it very important to reassure patients that this is not an STD. Yes. The other issue and I'm curious to hear how you discuss this with your patients. A lot of patients are really confused about HPV, especially women over 50, because HPV, human papillomavirus, of course, is a sexually transmitted infection. However, if you are diagnosed it, for argument's sake, when you're 50, that doesn't mean that somebody was necessarily stepping out in the past couple of years. True. Very true. Want to talk about that? Well, the human papillomavirus can be sexually transmitted, but it may not be due. You may be diagnosed at 50, but you could have had it, kind of harboring or asleep in your system for many, many years. It could have been from your first partner who had something on their penis that you didn't look at because you were afraid to turn the lights on, and it was a wart, and then you got HPV, but you had such most of the time there would be no evidence at all.
Right,
no
yeah, right. It could be from that, or it could be from nothing, and you have no idea. Because in all fairness, a lot of times males don't know that they have. Right, anything. And
there's no test that's really available for in a research setting, yes, but not for prime time.
Routinely, no. And that's why many people are advocating that the young men starting at age 9 get the human papillomavirus vaccine, just like young women should. But it could be nothing that you've done at all. You could have had only 3 partners in your life. And again, I'm like you. I don't really harp on how many partners you've ever had.
You could have had one.
Well, you could have one, exactly, and gotten this virus. You could have had
sex one time with one person and get HPV. In fact, about 80% of 20-year-olds who have ever had sex one time become HPV positive.
Right.
However, their immune systems are generally strong enough that they clear it by the time they're 30, which is why we don't recommend the HPV test until 30. I remember when the test first came out, and I said to my own gynecologist that I wanted this test, and she said, well, you have no risk factors. And, and again, we're friends. And I said to her, with all due respect, you didn't ask me any questions to determine that I had no risk factors. And she's like, you've been married for 100 years. And that's when I said, well, who's always the last one to know if she's in a mutually monogamous relationship? And I wanted the test.
So just give it
as far as I'm concerned, every woman over 30 should be having her HPV test. But anyway, so the other thing that women lied about in this survey was whether they've ever had an STD before. And that is relevant. Not
It is
all
very
STDs
relevant.
are relevant. So, if a woman is 40 and she had one case of trick when she was 20, okay,
Right.
that's not relevant,
Yeah.
at this point. But if she had an abnormal pap smear and had, a positive HPV test, it would save us a lot of time, money, and effort to just know that up front. Or chlamydia.
Yes.
Evaluating somebody who's presenting with infertility.
Huge
Or,
one.
So even though they might not test positive for chlamydia now, knowing that they had chlamydia in the past, or PID, pelvic inflammatory disease, or if they had gonorrhea or any of those other diseases, certainly if they have any risk factors for HIV, those are all really important.
Absolutely.
The next issue on this survey was alcohol usage, where most women said they didn't, and then smoking, where there were a lot of closet smokers
Yes.
who and what they said was they just didn't want the lecture. They're like, I know, and I don't want to hear it.
But we can smell it. That's what I find so odd. It's like, dude, you're not the putting on more perfume's not really helping. Not really helping.
And even if you do brush and floss your teeth, and use mouthwash, it's in your clothes.
Absolutely.
So that's an issue. And again, this is not, your doctor is not there to judge you.
Right.
That's not what this. And public service announcement, if you feel like your doctor is judging you, then it might be time to
find another
doctor.
Right.
Even if it's you or me.
Right.
Or to say something.
Yeah.
To say, I feel like you're judging. And I might say, I feel like you're projecting.
I love it.
Or if I was feeling particularly generous, I might say, well, why do you feel that way?
Why do you feel that way?
And I think, we joke about that question, and psychiatrists and psychologists are going to be sending me all kinds of hate mail now.
Sorry.
But I think it is really important sometimes for us to ask ourselves why we might feel that way.
I agree.
And
I agree.
what we might be putting on our patients.
So I have a question for you about that. I don't know if it mentioned or not, but I was thinking about how a glass is poured at a restaurant. I think the standard glass should be 3 ounces. I think that's right. Of wine.
I was thinking water when you were.
No. Oh, sorry. Yes, of wine. When we're going back to the alcohol abuse, and are you? Because I have patients who say, "Oh, I drink every once in a while, social activities, just like I smoke when I go to a bar." Are you going to a bar every night? That kind of thing. But right. But when you're at home, the glass of wine you might pour may be 2 servings. You think it's 1.
When you're out in New York, they're pouring 5 ounces or more in a glass of wine. And now I've noticed many restaurants will ask you if you want the 6-ounce serving or the 9-ounce serving.
Oh.
Or the 8-ounce serving. But a medical unit of wine is 3 ounces. And I knew that intellectually. I got it right on my boards. But I never really appreciated that till I went to Canada. I was in Quebec City. And I had a glass of wine. And they gave me this like teeny little 3-ounce glass of wine.
You're like, what?
What is this? I was like, this is a tasting portion? And I was like, no, that's like an actual portion.
That's hilarious.
So it really hit home for me. The thing I want women to know about drinking and smoking in a bar, and this is really interesting, is that studies have shown, we're learning more and more about gender differences in physiology. And yes, women are not just smaller men. There's many, many differences. And one of the differences is with respect to alcohol and smoking. The enzyme that metabolizes alcohol is called alcohol dehydrogenase. When women smoke, their alcohol dehydrogenase levels decrease. That means we don't metabolize alcohol as fast or as well as men. Men, on the other hand, when they drink and smoke, smoking increases their levels of alcohol dehydrogenase. So they're
very interesting
to metabolize alcohol quicker, faster, better. So we used to think that women just couldn't drink as much as men because we were smaller or we had a higher percentage of body fat, but it's actually a metabolic issue as well. And of course, the punchline is nobody should be smoking, men or women.
Right.
But women, especially young women who go to the bar and they're dieting and they haven't eaten anything and they, are just smoking just when I'm at the bar, and then they're drinking and they're not aware of how much they're drinking. This really can be a real problem. The other problem, I just lost my train of thought on this. The other problem is alcohol impairs your memory. But menopause also impairs your memory.
Yes.
But I did get back what I was thinking about. The other issue that we have to start being real with women about is the very impressive but depressing data that having just 3 servings of alcohol per week or more raises your risk of breast cancer.
That's frightening.
And this is not a judgy thing. This is not me saying, I think if you drink 3 glasses of wine a week or more, you're an alcoholic. It's me saying that be aware that if you drink 3 accurate servings of wine per week or more, according to these studies, you are at increased risk for breast cancer. And we do know that 250,000 women a year in the United States are diagnosed with breast cancer.
And again, that serving is 3 ounces, not 6 or 9.
3 ounces, yeah. So that was a real eye-opener.
That's an eye-opener
to me.
Yes.
I was, not, obviously I didn't know that before the study came out.
Yeah.
But, I wouldn't have thought that just 3 glasses of wine a week would have such a significant effect. The other thing that young women need to know who tend to binge drink on the weekends, even if it's only once in a while, that can cause a condition called fatty liver disease, which when you and I were in medical school, that was something that we really only saw in alcoholics.
Really rare.
And frat boys.
Yes.
But, now fatty liver disease is becoming increasingly common, even in children, not because of alcohol, but because of diet and, obesity.
Yes.
That's another issue. Anyway, I could talk to you all day long.
I know. It's so great.
So I just want to ask you a couple of wrap-up questions.
Okay.
The first is, if you could give any health advice to your 21-year-old self, what would it be?
A couple of things. One is drink more water. And the second one, maybe 3. Drink more water, sunscreen when you're at the beach, even if you're a brown person, because brown people get skin cancer. Yeah. And the third one is moisturize every night. Put moisturizer on your face and skin every night, because you walk around at 30 years old looking like a Shar-Pei. Not a good look. Not a good look. I do, when I do talks at high schools and colleges, I always talk about, in fact, I've got to do one in a couple of weeks at the university here in town in Charlotte. And I'm going to mention that again, put it, even if it's lotion, put something on your face every night. Because then when you're 40 and 50, you're like, oh my God, really? Yeah. And it really makes a difference. Little things you don't think about.
Well, and sun exposure in your 20s also really makes a difference.
Huge.
I'm definitely paying for that now. And then my last question is just, what is the number one health issue that you think women need to pay more attention to?
Heart disease.
Okay.
Heart disease, including myself, because I think that we get so focused on breast cancer and, infertility when you're trying to get pregnant and all the other things that, HPV even, we get so focused on those things that heart disease is the number 1 killer of women in the U.S. So I think that, being a little more heart healthy, conscious in diet, exercise, activity, again, not judging, knowing that I need to do the same. And maybe that's why I'm saying it, to reinforce it to myself.
Yeah, you're talking to yourself.
Just talking to, I'm saying self saying, huh? Yeah.
We're
yes.
sharing. Well,
right.
80% of your risk of heart disease can be reduced by behavior changes.
Yes.
So, that really is a great, great message to end on. Thank you so much for talking to us in the ladies' room.
You're welcome.
Have you back again sometime.
Thanks for the invite. I would love it. Thanks, ladies.
Take care. Bye.
Okay, you too. Bye-bye.
That's all we have time for today. But let's keep the conversation going on Twitter or Facebook at Dr. Donica. And please join us next week for another episode of In the Ladies' Room with Dr. Donica. Real conversations with real women about really intimate topics.